Welcome to Beyond Extraordinary, brought to you by LCMC Health. We are an 8-hospital system providing health, care, and education to the greater New Orleans area. We are a health system with 3 academic medical centers. Our AMC status means we have our finger on the pulse of the latest treatments and technologies in medicine, and we're bringing it right to our community. I'm your host, Kristen Gradney, Chief Wellness Officer. Today, we're joined by Dr. Annelies De Wulf, Director of Violence Intervention Services at University Medical Center New Orleans, and Dr. Erika Rajo, Director of the Seeds of NOLA Trauma Recovery Center, which is housed at UMC. Thank you both for joining us today. So I'm going to ask, introduce yourself, tell us a little bit about yourselves and how you got to this work.
Well, thanks for having us. I came to the work of violence intervention through my role as an ER doctor at UMC. I did my residency at the interim hospital, the LSU interim hospital, and then left for fellowship and then came back and had been working with survivors and those who sadly did not survive violence for so many years. I was starting to feel hopeless with all this exposure and all this breaking bad news to patients and their families. And it felt like what we were doing was patching things up, if when possible, but that we weren't doing anything to stem the flow of people coming in. So in that role, I also ended up working closely with a couple of the community-based violence intervention programs that have been present in the hospital during different periods of time, including Ceasefire New Orleans, the Office of Gun Violence Prevention, and Cure Violence. These were all different iterations of violence prevention professionals who came into the hospital and engaged with survivors and the families of people who had been shot to try to reduce violence. And I got really bought into that model and felt like we had an opportunity to put that within our hospital and really invest in our patients and their recovery and try to stem some of that flow on the front end.
And I think it might be something that has happened for a long time, but might be new to some of our listeners to understand that hospitals play a role in violence intervention and interruption as part of the community approach to reducing violence. So I'm looking forward to hearing more about that. Dr. Rajo, tell us a little bit about yourself.
Yes. So I'm born and raised in New Orleans, and I left for grad school, and I always wanted to come back to help my community. I felt like it wouldn't feel right to stay somewhere else and invest in another place when I love New Orleans. And, this opportunity, I wasn't setting out to be a trauma psychologist or run a trauma recovery program. It kind of was serendipitous, and there was an opportunity presented to me. And then when I looked back at my career, I realized there was a thread of trauma throughout. And I think what I enjoy about this work is being able to be with people in their most vulnerable moments. We see patients sometimes hours after the worst thing that's ever happened to them. And while there's amazing doctors and medical teams around them, like Dr. De Wulf, helping to make sure that their medical is in check, that they're stable. There really aren't a lot of people who are checking on their emotional or mental well-being. So I realized how important that was. And every day it really is a privilege for people to trust us, to let us in, to help them navigate the difficult time that they're going through.
Sounds like heavy but very important work. So, these moments that you all step into people's lives really do impact not only the individual but the community. So thank you for that. And we are so honored to have you both in our system doing this work. So I'd really love for you guys to tell us really what this means. Like, describe the work, tell us what your programs are about, how they really show up every day.
Yeah, so starting from when people come to the hospital shot, we have violence interrupters that are housed in the emergency department 7 days a week. And they're heavily staffed on the kind of busier times, so often late night, evenings. They're not business hour jobs. They are present when a family comes looking for their family and without any information. They offer some emotional support and some kind of work in this sort of liaison role while people are waiting angstily to know what happened to their loved ones, while we on the medical side are doing our resuscitation. If the individual is stable enough to speak with a violence interrupter, the violence interrupter can go to the bedside as soon as they're kind of stable to talk through, how are you doing? What do we need to do to keep you safe? And over the longer term, try to get buy-in into this idea of we can work with you over the long term to help reduce the risk of violence. We know that people who've been shot are disproportionately at a high risk for recurrent violent injury, and that's what we're trying to intervene on this moment. The population of people who are shot don't always willingly come to the hospital and engage in services and have all this trusting relationships with the medical system. So this is this moment where the paths cross, and we try to take advantage of that. If the person has a devastating injury or if they don't survive, our violence interrupters come with us, the providers, to break that news to the family. And that means that they're there kind of helping with that emotional support, but they're also there able to hear when people are thinking about, is there a retaliation planned? Are there other adverse effects, or is more violence going to follow from this? And really use some of the best practices that we know from the public health literature to try to, and the psychology expert consensus, to try to reduce the risk that people are going to go out and respond to that. We know that in gun violence, most gun violence happens between people who know each other, and one shooting can lead to many more cycles of violence. And so what we try to do is just interrupt that from the front end. During the time that people are hospitalized, our interrupters continue to visit with them and talk through start to think about what is it that you want your life to look like, and then try to get them to engage on the long term with our violence intervention specialists, who are housed together with the trauma psychologists in the trauma recovery center, to identify people's strengths, work with them to get to know them, learn about their strengths, learn about where they could use some assistance, use case management, use motivational interviewing, take advantage of the fact that we have trauma therapists right alongside us to help that healing process, and then think through short-term, medium, long-term, what does a life that you want look like, and try to help people get there. The idea being, people with choice and options and stability don't generally choose to be at risk and have other people be at risk. And so how do we give people the space to work through that?
And it sounds like, Dr. Rajo, your team is really on the continuum of care that starts with the violence interrupters and in the ER, but you all continue this work beyond, right? So tell us a little bit about the program.
Yeah, so we are the continuum of care. There's some continuum on there, and too, it's a bit confusing, but we also have so an inpatient side of things where, similar to Dr. De Wulf's team, but not exclusive to victims of violence, the trauma psychology team sees all individuals who are admitted for a traumatic injury. So that may be a car accident, a fall, work-related injury, and of course, community violence. And we see them while they're in the hospital. We screen them for trauma-related distress and alcohol use disorder and depression. Some of those are requirements of the American College of Surgeons in order to maintain level 1 verification for a trauma center. And we provide support to the family members who are at the bedside, as well as the patients. And really, a lot of times, like Dr. De Wulf was saying, these are people who wouldn't step foot in a mental health clinic. And so it's an opportunity to really provide education and brief intervention in the form of prevention, because, a lot of times these patients haven't even processed what's happened to them. So it's not like they have PTSD right then and there. We're just giving them the information, what to look for. And then sometimes when they discharge, it may be months, weeks, or longer, where they give us a call and say, hey, I'm struggling. And they call us because we do have an outpatient side of things, which is the Trauma Recovery Center, where we provide wraparound services for trauma survivors. We have therapy. Therapists provide evidence-based treatments like EMDR, prolonged exposure therapy, cognitive processing therapy. We have psychiatrists prescribing medication. We have case managers who help with kind of those secondary stressors that come up. When you have a trauma, life doesn't just pause. It keeps going. And so there's a lot to manage. And there's also a lot of things that come out of the trauma, whether it's financial, housing, and our case managers are there to help so that individuals don't have to, and families don't have to pause the emotional healing to focus on like the practical things. They can kind of do both at the same time. And then we also have trauma survivor support groups to provide kind of that peer support that can be so valuable for trauma survivors that are recovering.
It sounds like you guys are really making an effort to address all the components of healing, especially the mental health components. But to your point, life continues and nobody thinks about this person going back out into the community, into their lives and carrying all of this. So I would imagine that you probably have a lot of community involvement, community organization support, even governmental support. So tell us what that looks like.
So for the violence intervention program, the reason we were able to start is because this is in partnership with the health department, the New Orleans Health Department, now Department of Health and Human Services. And they provide some funding. And then they kind of loop us into this ecosystem of violence intervention. That is, we have partners at Manning's Children's. We have partners with Ubuntu Village and their Peace Ambassador program. And we have a lot of accountability with our reports and our working through cases quite frequently. One partnership that's very important to the work that we do is with the Peace Ambassadors with Ubuntu Village. We are in the hospital limited to what we're able to do. So we have patients who come to us either in the hospital or into the clinic. We do everything we can to support them from our medical system, but we're sort of limited in our outreach to the medical spaces. We depend on Ubuntu Village to take the same work into neighborhoods, to people's homes. And we will often, with permission, coordinate care for patients, make sure that we can bring all the resources that we can to bear. We depend on them when there's ongoing conflict that requires mediation. There are experts for that. And when we need to think about somebody needs to get out of their neighborhood because the issue is very unsafe around their neighborhood, then we really collaborate both with the health department, with the Ubuntu Village Peace Ambassadors, and whomever is able to bring resources to bear to make that happen. So we work quite closely. It's tricky since we are in the health system. Everything is very HIPAA compliant, so patient health information, we guard that very closely. But with permission, we're able to really bring all these different partners on board and try to come up with good plans for them.
I think that's so important that you acknowledge that, right? It's with permission and really in partnership. So if someone comes in as experiencing violence, it's not like we are just reaching out and doing all these things around a person. It is really with them kind of driving the desire and at the center of it and on their time, as you mentioned, in a way.
Yeah. Everything that happens in the center is trauma informed. And
tell us what that means.
So trauma informed means everyone who works in the center and all the policies and procedures are all come from a place of understanding that trauma is pervasive and that it impacts a lot of different things about an individual and their lives. And also the goal is to not re-traumatize people. So, when we're thinking through like how a process is done, we're making sure that we're not going to be insensitive to any type of trauma. So words matter, right? Language matters. And so we're very intentional with our language. And yeah, so everyone in the center, everyone who works in the center, including the front desk, our patient access person, is trained in trauma-informed care. And Dr. De Wulf's team is also trained in trauma-informed care. So there's that continuity of care because, you hate when you create like a safe bubble in one place and then you refer to somewhere else and that bubble is disrupted, it's popped. And so you want to be able to have a handoff and trust that your partners or your collaborators are going to provide that same trauma-informed care.
Seems like you all are very thoughtful in the way that this presents and shows up in an individual's life and really in an individual. So I'm grateful to you all for that because I think that not as healthcare, we don't always think about the whole person in that way. And I think that it has probably had an impact in our community. And I'd love to hear your thoughts on, in New Orleans recently, we've been recognized nationally for significant reductions in violent crime over the past few years. And from your perspective as really the front line of this work and working with individuals, do you think that people may not fully understand about what actually contributes to that kind of progress and how this work contributes to it?
I think there's a lot of pieces that are have to be unpacked to kind of figure out how to reduce violence. I think we know and we've seen enough kind of surges in violence to see some of the things that contribute to violence, including economic instability, lots of downtime with nothing to do with your time, lack of access to resources in a community, all these social determinants of health, exposure to trauma, exposure to violence, all these things put together make a perfect breeding ground for violence. What we have seen, I think probably the biggest thing that has helped reduce violence in the city is having people get back to work, have people have stable jobs, have people have choices. And what we try to do is help get people on that path to those choices and to stability and being able to not have to hustle to put food on the table so hard, be able to think through what is meaningful and how does my role in this community work. So I think there's the social determinants of health that we're trying to address, but that also on a bigger level, the entire city and the community has to address. There is this opportunity to build trust across professions and workforces and communities that haven't traditionally been very close. And I think when we think about how do we solve these problems, like nobody in a silo is going to solve it. The business community isn't going to do it alone. The healthcare community is not going to do it alone. Impacted communities have to have a voice, and they also need to have the support from everybody else who is in it with them. So I think one of the big important parts of what we're trying to do and what we need to do more of is building that cross-community trust and collaboration and really see it from everybody's perspective because we're all so impacted by it.
That's right. Dr. Rajo, from your perspective, what do you think?
Yeah, I think that so the trauma recovery piece is key as well, and especially in collaboration with the violence intervention, because in order for someone to re-engage in the community, in their job, in their social circle, they have to heal from what happened if they have PTSD. And so that healing process is important because, you've heard people say hurt people hurt people. We did a study, an outcome study for the first 3 years of our trauma recovery clinic, which initially opened in 2017. More recently was the expansion with the city funding. But those initial 3 years, what we found was that people who came to our clinic and received treatment for their PTSD symptoms, not only did they see a reduction in their PTSD symptoms, but they also they felt the need to carry a weapon was less. So, because of hypervigilance and the fear of threats around them, especially people who have experienced community violence, they felt like they needed to carry a weapon to be safe, to leave their house, even in their house. And so getting treatment helped reduce that likelihood, which we can maybe assume would contribute to, less violence.
Wow, that's profound. I mean, that's huge, right? And I think that that's something that we may not think about, right? Like if you've been the victim of violence, you feel the need to arm yourself, which could lead to more violence. Do you guys know how much of our community here has been impacted by violence?
I mean, I feel like everybody's impacted by violence here. I think either primarily or secondarily, the fear that exists in communities pervades all of New Orleans. And then, of course, when I think we have this opportunity to see what people's lived experiences are. People, trauma gets passed from generation to generation. We've all been exposed to the environmental trauma and so many different versions of trauma that it sort of tends to layer. And that's when it seems like you really need additional support. It's not just like a couple of people who care about you and try to make this work. That's where you really depend on these partnerships with the professionals to help unpack that, figure out short-term, long-term, where do we go from here, and prevent that changing everybody's trajectory subsequently.
Yeah, and I think that because so many people have been impacted by violence here, often like patients that I see in the hospital after a shooting or something, if I'm asking them about trauma-related distress or some symptoms, common reactions to trauma, often they won't endorse it. And then if I sit and explore that further, it's because that's their norm. That's been their entire existence. So being on edge or jumpy, that's not something new to them. So they're not going to say, yes, this is because of what just happened, right? And so when you think about that, I mean, it's pretty profound. And so education to the community about what trauma looks like and how it might disrupt your life, and then also pathways to recovery are super important for healing.
I think that's so important, what you guys just said, that really like so many people are living this their whole life. The whole community is possibly impacted, right? Because we're all, when you walk out of the door, do you move differently? Are you thinking differently? And so going back to that concept of trauma-informed care, just as community members, it's important for us to recognize that when we encounter someone, we may be encountering someone who has had trauma in their life. Just give us a tip on like how do we move through the community differently, more from a trauma-informed lens?
That's a good question. I think just being attuned both to your own, I think it starts with self, right? Like, because it's hard to show up for other people if we're not showing up for ourselves. And so being attuned to yourself, knowing your own like trauma and trauma triggers and the signs that you're activated, and taking care of yourself in the ways like you need to when you are activated, because then you can be available to observe signs in other people, to notice when other people that you're interacting with might be stressed or having a trauma response or just activated, and then not judging them, kind of not thinking about what's wrong with this person, and really trying to take a more empathic stance and like, I wonder what happened to this person and why they're responding this way in this moment. Something must have happened, right? And not in a judgmental way, really just in a compassionate way.
Thank you for that. I think that that's important.
I love that answer. And then I think there is also a tendency when people are frightened by violence around them there is a tendency to have like a dip in compassion and to want to sort of separate oneself from the people who are most impacted in a self-protective, wanting to have a bubble and be like, that happens to other people because they're not good people kind of reflex. And what we work both in the emergency department really hard for, as well as in the violence intervention program, is to really check those reflexes and to bring back that whole concept of there's not bad people. It's like what happens to people, and community violence is an epidemic that is impacting some communities so disproportionately and so unfairly. And if you're not living in the community, that doesn't make you any better or any better equipped to deal with challenges. We just have to remain empathetic and understanding and supportive through that.
Why is it so important that we really treat these matters of like public safety as a public health issue?
We have a roadmap if we look at data and evidence, and it makes sense in the way that treating HIV or treating COVID, preventing transmission, all of that stuff, there's a map for how to do that. We know that gun violence is transmitted similar to an infectious disease, sort of from person to person in a community. We know that there are ways to reduce that risk of transmission. We know that we can look at the data of what are the reasons why certain communities are more impacted, and we can address that from a scientific standpoint. And then we know what best practices are the best ways to engage with this population. It gives us a path that's less about how are we separating people out of a society so they don't impact that society, but more of a path of how do we protect people who are highly vulnerable, highly at risk for being hurt again? How do we bring them into the fold, so to speak, and how do we support people to make decisions that will keep them safe and reduce sickness and death?
Yeah, I'll just second that, and then just, I guess, highlight that trauma and violence doesn't just impact one person or one family or one neighborhood. It really affects the whole community. So, yeah.
I appreciate that you brought up not only this component of individual accountability, but really that there is a roadmap. If we look at this truly as a public health issue, there are root causes, there's transmission, there's, generational aspects to it, all of those components that, as society, we sometimes take a step back and just say, if this person would just act differently, but don't think about the whole environmental component and all the other components that are there. So that was a really great way, I think, for us to be able to relate as a public health issue. And for our listeners who may not realize that the resources that exist at UMC through both of your programs are available, what are some of the ways that your teams would help patients rebuild stability after experiencing violence? I know that we've talked a little bit about what exists, but how does that really translate in the day-to-day? So if someone has been shot in the hospital, they show up to the ER, what is that person's pathway through your programs? Whether it's counseling, case management, connecting to the community resources, as you've mentioned, if you could talk us through what that looks like for an individual.
Yeah. So if somebody comes to the emergency department, they meet a violence interrupter.
And tell us a little bit more about who is a violence interrupter.
A violence interrupter is a trained, certified professional who has been recruited from the community, who has empathy and familiarity with the issues that are impacting highly impacted communities, who are able to relate to people, speak and understand, and act as a bridge sometimes between highly impacted communities and healthcare professionals, be able to translate a little bit.
Would they have some of the same lived experience, maybe?
Yes, yeah, often yes. Not exclusive, experience can be many different things, but we want people who understand what it feels like to be faced with very difficult choices about what are the next steps after an injury. We want people who have learned what consequences of decisions can look like, what what it means to have a loved person be hurt. These are all part of those decisions. And then they're also, they go through a lot of interviews and training in order to make sure that they can relate and they can be deeply empathetic and emotional and also be okay in that, because that's a lot of skills. And being able to traverse a medical system and do electronic medical records and also be these really talented people at the bedside.
Very special
Yeah,
people.
they're really unique and amazing. They initially, what do you need right now? What do you need in terms of a toothbrush for a family member versus do you need some additional emotional support from the professionals, the trauma psychology team? Do we need to think about where you're going after discharge? Did the shooting occur at your house? Did it occur in your neighborhood? What do we need to do to keep you safe in the very short period of time? And then we bring the violence intervention specialists who are also recruited as individuals with a bit heavier of a case management background, but also that credibility, that familiarity, and that empathy. And we try to bring them to the bedside so they have an in-person handoff, know who they are going to follow up with on the outpatient basis. And then after they're discharged, they come back to the center, the Trauma Recovery Center, for their clinic appointments. During their clinic appointments, they get a needs assessment, they get a strengths assessment, and they talk through what are the most immediate issues we need to address and what are the long-term things you want to achieve. Sometimes getting to that long-term goals takes months of working through what's happened. And at each of those moments, when people display some of the symptoms or challenges related to their trauma, we try to facilitate that warm handoff and that cooperation and coordination with the trauma recovery staff. So that if somebody comes for an appointment, they can see their trauma psychologist, psychiatrist, and violence intervention specialist all in one visit. That's what we strive for.
And also on the inpatient side, so like if someone's in the emergency room and then they're admitted to like the trauma ICU, so that's where trauma psychology will come in and just do more of that emotional support, but from like a trauma standpoint. And usually that involves just some brief education about common trauma reactions, both to the patient and their family, letting the family members know that they too can develop PTSD, even if they weren't present for the event. And then depending on, the patient and what they're endorsing, what they're receptive to, then we might do some brief interventions, like teach them mindfulness or grounding, deep breathing, some strategies that they can use while they're still in the hospital. And then we always give them resources, and one of those resources is the Trauma Recovery Center, letting them know we can get them scheduled in there so that they can start therapy if they're interested right after discharge. But we also give them other community mental health resources, and we want them to have options, and we want them to choose what's best for them. And then when they do come to the center, we'll do a comprehensive intake to decide like what do they need? Is the Trauma Recovery Center best for them? And then if so, we will get them scheduled with a therapist or a psychiatrist, like Dr. De Wulf said. And in therapy, we are doing evidence-based trauma treatments. So, that can look different for different people. But if the most common ones that people are asking for are EMDR, which is eye movement desensitization reprocessing therapy. That's a lot of words, but it's very effective. And then prolonged exposure therapy, which involves people really recounting their trauma narrative repeatedly, recording it, going home and listening to it, and then in a systematic way confronting things that they're avoiding since the trauma. And so it's a lot of work. It takes so much for trauma survivors to show up to each session. It takes so much courage for them to face these things that, are understandably terrifying to them in that moment. And they do it all the time. And to be on the other side of that and kind of guiding them through it, it's amazing, because I'm like, I don't even know if I could do that, So we talk a lot about vicarious trauma as healthcare workers and as people who work in this area of trauma. And I really feel like I'm blessed to get a lot of vicarious resilience in my work as well, because every single day I see people navigating things that to me are unfathomable. And while they will say, "Thank you so much, you saved my life," I'm like, how did I save your life? You literally showed up and you did this for yourself. And it took incredible strength and courage and just persistence, and hope.
That is beautiful. And I was actually thinking, I was wondering, our last question is, what do you do to support your well-being? And in this work, I imagine you all see a lot, you hear a lot, you probably feel a lot. So, this question resonates a little differently, I think, with you both than it does with most of our guests. But tell me, and you mentioned a little bit, but what do you do to care for yourself and support your well-being?
Yeah, I do a lot of things as a trauma therapist. I practice what you preach. So I go to therapy regularly, and I run. So for me, after work, running is kind of a way to like shed my day. I also love animals, so being around my animals, or like watching an animal show or something with animals, is very relaxing for me. And then every night I meditate, and that's really an important practice for me that I've been doing for about 10 years. That is just part of my routine. And I think on different weeks or different days, what works, it varies, but having a lot of different things and of course, social support, is key, because you can't just use one thing every time. So yeah,
Lots of tools in your toolbox.
lots of tools.
And Dr. De Wulf, tell us, what do you do?
So I think one thing that helps is knowing that each part of the work matters. So even if some of the mundane little challenges can be a little aggravating at moments, the bigger picture, kind of like remaining focused on the big picture, is important. I think I'm blessed to live in New Orleans, where a good day involves dancing in the street. I think that's a very healing process.
Yes, I forgot to say that. Music.
And dance. Even if I'm not a terribly good dancer, I think it's just enjoyable to do it. I'm fortunate to have a very close family that we spend a lot of time together and try to get out of town and look at nature and commune with the greater things, and get out of city sometimes. That's important for me. And then exercise and healthy eating, and trying to take that time with my kids and the people that I hold dear.
Well, thank you for sharing that about yourselves. I think that also helps us understand, how you do the work and continue to do this work that's so important to our community. So thank you also for the work that you do, which is so important, not only to the people that you touch every day, but to the greater community, obviously. And thank you all for listening. Join us as we go beyond extraordinary on the second Tuesday of every month.